All right, so quickly we're going to run through some post-op eval questions. Following a surgical procedure, the patient should have a bowel movement after how long? 6 to 8 hours post-surgery, the patient should have had a bowel movement. Post-operatively, you are treating a 100-kilogram patient. What is the amount in milliliters per 24 hours of maintenance fluid that this patient should receive? 3 liters. This was calculated based on 30 milliliters per kilogram. This is different than 421, but this is what was listed in the PowerPoint. What are the 3 stages of post-surgical wound healing? What are the 3 stages of post-surgical wound healing? First stage is going to be inflammation, which occurs during days 1 through days 3. Then you have proliferation, which is days 3 through 12. And then lastly, you have remodeling, which is going to be days 8 and above. So we have inflammation, proliferation, and then remodeling. Represent the 3 stages of post-surgical wound healing. What defines a chronic wound? What is a chronic wound? A chronic wound is one that has not healed by 3 months. An example would be any of the various types of ulcers, such as venous stasis, arterial, diabetic, decubitus, or pressure ulcers. What is a seroma? What is a seroma? Seroma is a collection of liquefied fat, serum, or lymphatic fluid, often opened or aspirated. It is typically a benign finding found usually at the surgical incision site. What antibiotic can be used in gram-positive post-op infection? What antibiotic can be used in gram-positive post-op infection? Any of the 3rd-generation cephalosporins, such as cefotaxime, ceftriaxone, or cefazodime. What are some antibiotics for gram-negative post-operative infection? What are some antibiotics for gram-negative post-op infection? 2 options here can be aminoglycosides such as gentamicin, tobramycin, or any of the fluoroquinolones. Name 3 antibiotics that can be used in post-operative anaerobic infection. Name 3 antibiotics that can be used in post-operative anaerobic infection. Clindamycin, metronidazole, chloramphenicol. What is the treatment for necrotizing soft tissue infection? What is the treatment for necrotizing soft tissue infection? So if you have a Clostridium infection, you're going to use penicillin G plus clindamycin. Penicillin G plus clindamycin for Clostridium infection. Now, if it's a non-Clostridium infection, any necrotizing soft tissue infection can be treated with a 1st-generation cephalosporin. Example will be cefazolin. When should you discontinue treatment for a post-operative infection? When should you discontinue antibiotic treatment for a post-op infection? You may discontinue antibiotic treatment if the patient is afebrile times 48 hours. Now you have 2 options in this scenario. You could either discontinue therapy altogether, or you could change to an oral prescription for 7 to 10 days additional. What type of pain management should be offered to a fully alert patient who just completed a surgical procedure? So what type of pain management should be offered to a fully alert patient who just completed a surgical procedure? It should be offered an IV patient-controlled analgesic pump or a PCA pump. In contrast, continuous IV narcotic infusion can be used when the patient cannot manage their own analgesic, such as those in the intensive care unit. These are typically patients that are not fully alert. So if they're fully alert, PCA pump. Not fully alert, they can get continuous IV infusion as normal. What are the 5 W's of post-op infection? What are the 5 W's of post-op infection? Also try to name them in order of prevalence. First is wind, water, wound, wonder drug, and walking. So the order of prevalence is wind occurs first within the first 24 or 48 hours post-operatively. And this is referring specifically to atelectasis. This can be treated with intensive spirometry. Next, you have water. We're referring specifically to UTIs. This can occur between days 3 and 5 post-op. This can be treated by discontinuing the Foley catheter or by antibiotic therapy. Third is wound, An infected wound can occur anytime after post-op day 3, typically between days 5 and 7. Treatment includes antibiotics and IND. If it's an early infection, so days 3 to 5, you think necrotizing soft tissue infection. If it's a later infection, days 5 through 10, you're thinking more of a superficial abscess. Fourth is going to be wonder drug. This occurs day 7 and above. You're going to want to check all drug interactions and treat, obviously, by discontinuing the drug. Last is going to be walking. This is referring to DVT or PE. There was no mention here as far as time, but I'm assuming this is consistent with the amount of immobility the patient will have. So that's why I listed it last. So to review, we have wind, water, wound, wonder drug, walking. Memorize it. What is the most common cause of post-op infection? What is the most common cause of post-op infection? Most fevers are believed to be from normal response to surgical trauma. So most fevers are normal response to surgical trauma. What are the 3 components of Virchow's triad? What are the 3 components of Virchow's triad? Stasis, hypercoagulability, and endothelial damage. Stasis, hypercoagulability, endothelial damage. 2 preventative measures for DVT. What are 2 preventative measures for DVT? Intermittent sequential compressive devices, intermittent sequential compressive devices, SCD, or low molecular weight heparin or subcutaneous heparin. A patient is NPO post-op until what 2 criteria are met? A patient is NPO post-op until what 2 criteria are met? First is going to be bowel sounds present in all fields. Second is the patient passes gas or flatus. List 9 factors of abnormal wound healing. List 9 factors of abnormal wound healing. This is, remember, by the mnemonic didn't heal. You have diabetes, infection, drugs, mainly steroids in this case, nutritionals, N, T is tissue necrosis, H, hypoxia, E, excessive tension on the wound, A, another concurrent wound, or L, a low temperature. So once again, the 9 factors for abnormal wound healing are characterized by the mnemonic didn't heal, and those were diabetes, I, infection, D, drugs, N, nutritional, T, tissue necrosis, H, hypoxia, E, excessive tension, A, another concurrent wound, and L, low temperature. What are the 4 surgical wound classifications? What are the 4 surgical wound classifications? Class 1 is clean. Class 2 is clean contaminated. Class 3 is contaminated. And Class 4 is dirty. So to review, Class 1 is a clean wound, sterile wound. Class 2 is a clean contaminated, meaning no gross contamination. However, the minor breaking technique occurred. Examples include wounds left open for drainage or reopen wounds to remove wires or pins. Class 3 is going to be contaminated. These are surgeries where a major break in operative technique occurred. Examples include spillage from the GI tract or entry into the GU or biliary tract with infected bile or urine. Class 4 wound is going to be dirty, often involved in wound debridement, abscesses, or infected wounds. What vitamin and mineral deficits can result in abnormal wound healing? What abnormal vitamin and mineral deficits can result in abnormal wound healing? So you have vitamin C deficiency, vitamin A deficiency, vitamin K, and zinc. So basically all the fat solubles, so A dec minus the D, and then zinc deficiency. So vitamin C deficiency is characterized by bleeding gums, poor wound healing. Vitamin A deficiency. Vitamin A, this vitamin contributes to lysosomal activity and directly counteracts the effects of glucocorticoids. So if it counteracts glucocorticoids, a deficiency will result in higher glucocorticoids. And remember, glucocorticoids inhibit wound healing, so this would have an indirect effect on wound healing being decreased. Next, you have vitamin K. This is metabolized, is impeded by antibiotics. Decreased levels result in deficiencies in clotting factors 2, 7, 9, and 10. And then lastly, you have zinc deficiency results in dry, flaky skin or alopecia. And the ones that don't specifically say abnormal wound healing on the slide were taken from his homework assignment. So I'm assuming that's what he wanted us to know about these vitamins specifically. Describe the mechanism of malignant hyperthermia. Describe the mechanism of malignant hyperthermia. Patients with malignant hyperthermia have genetic abnormality that allow for excessive calcium accumulation secondary to a particular anesthetic agent. The clinical manifestations are due to calcium overload within the skeletal muscle cells that leads to cellular hypermetabolism. Sustained muscular contraction are then broken down, resulting in rhabdomyolysis, anaerobic metabolism, and acidosis. How does someone inherit malignant hyperthermia? How do you inherit the malignant hyperthermia trait? This is an autosomal dominant hereditary condition. Autosomal dominant inheritance. So what are two common triggers of malignant hyperthermia? Two common triggers of malignant hyperthermia. You have succinylcholine and inhaled halothane gases. What is a gold standard for diagnosis of malignant hyperthermia? Gold standard diagnosis of malignant hyperthermia. You have IVCT, in vitro caffeine halothane contracture test. So as it's named, the positive test occurs when contracture of muscle fibers occurs due to either caffeine or halothane gas. So again, it's in vitro caffeine halothane contracture test. So the name tells you how it's positive or not. What is the treatment of malignant hyperthermia? What is the treatment of malignant hyperthermia? Discontinue the triggering anesthetic agent, as well as dantrolene given via rapid IV push. What are 4 complications to malignant hyperthermia? 4 complications to malignant hyperthermia. You have rhabdomyolysis, renal failure, myopathy, as well as death. Again, you have rhabdomyolysis, renal failure, myopathy, and death. What prevents outside air from entering the pleural space during chest tube insertion? What prevents outside air from entering the pleural space during chest tube insertion? A water seal. That's it. Hope it was helpful.